going to be the main chunk of this talk, as you may not be surprised about. It's worth knowing the anatomy, at least in this level of detail. The tonsils are very vascular, and complication of tonsillectomy is bleeding. So know that there's multiple vessels feeding the area. Innervation is via the 9th and 10th cranial nerves, and there are large veins at the top, middle and bottom of the tonsil fossa on each side. It's not uncommon for the tonsils to become infected, and when that happens, it's usually, if it's bacterial, then group A hemolytic strep or H influenza, although becoming less common with proper vaccination. Plenty of infections are viral, and when considering glandular fever, remember that the monospot test is not particularly accurate, and it's certainly not accurate early on. The most useful thing for considering glandular fever, apart from clinical assessment, is the differential white cell count. So if you see the lymphocytes being higher than the neutrophils, it's probably glandular fever. And the Paradise criteria is what forms the basis of the recommendations for tonsillectomy, which are fairly well known, I think, amongst most trainees, which is 7 episodes of proper tonsillitis in a year, 5 episodes in 2 successive years, or 3 episodes for each of 3 successive years, or 2 quinsies. The latter, less common in children, but does occasionally crop up in teenagers. The other indications for taking out the tonsils in kids is obstructive sleep apnea. So the symptoms of OSA, it presents with snoring, an extended neck, open mouth, restlessness at night, if that's supposed to say restlessness, gasping or tracheal tug, recession, daytime lethargy, behavioural changes. Those are all fairly difficult to really categorise, and they can be quite soft signs, but the most useful diagnostic sign is witnessed apneic episodes. But it is possible to have OSA without that being witnessed, and therefore there's a useful test of a sleep study which can help. The problems with OSA, it can interfere with educational milestones through tiredness in the daytime, failure to thrive. In severe cases, cor pulmonale, and in very rare circumstances, death, although that was actually in the popular press just this week about a child who died. And during my fellowship in Sydney, there was one child who died while on the waiting list of asphyxia overnight. So it definitely happens, but it's very rare. With sleep disordered breathing, oh dear, now that text is supposed to slide up. Oh, well, I'll just tell you. Sleep disordered breathing and obstructive sleep apnea are on a scale from normal breathing through snoring, upper airway resistance syndrome, and OSA at the other end. Now, not every child with suspected OSA needs a sleep study. They can be difficult to come by. They can have long waiting lists in some hospitals. So if there's those features which I've mentioned above, then that, with large tonsils or nasal obstruction, then that's enough to say that's a clinical diagnosis of obstructive sleep apnea. But those cases where there's clinical doubt, or those cases where there's definite OSA, but you think there may be severe OSA and possibly a need for intensive care admission, then a sleep study can help. Domiciliary sleep studies are definitely less diagnostic than polysomnography, but they have the advantage that they're much, much easier to perform. They're more convenient. They can be done at home. And they are sensitive for moderate or severe obstructive sleep apnea, but it's not possible to exclude mild OSA on a domiciliary sleep study. So therefore, if you think that there's enough information to clinically diagnose OSA, then a domiciliary sleep study is probably not going to help, because if it comes back normal, it doesn't mean that there's no problem. Polysomnography is the definitive investigation, and there's a few definitions that are useful to know. An apneic episode is a pause in the breathing for the duration of 2 respiratory cycles. Hypopnea is a 50% reduction in nasal air pressure, also for 2 respiratory cycles, with the associated with 3% desaturation. And then if there's a reduction in nasal air pressure which doesn't fall by more than 50%, then it's referred to as respiratory effort-related arousals. So yeah, I've mentioned there, the reasons to consider polysomnography is if there's discordance between the symptoms and the anatomy, for example, good nasal airflow or small tonsils, or if you suspect complications, a child who has a diagnosed syndrome, neuromuscular or craniofacial problem, especially mucopolysaccharidosis, any child who for any reason has a gastrostomy or is wheelchair bound, severe obesity, for example. And the reason is, firstly, considering which centre it's safe to do the procedure in, whether it can be a district general hospital or if it has to be a regional tertiary referral centre, and also whether what level of post-operative observation is going to be necessary. Interpreting polysomnography, it's a complex topic, it's a specialist area, but in brief, the apnea-hypopnea index is the main outcome, and less than 1 is considered normal, 1 to 5 mild OSA, 5 to 10 moderate, and more than 10 severe OSA in children. So slight difference with the numbers there to the range of normal in adults. If a child doesn't reach the diagnostic criteria of obstructive sleep apnea, they may be diagnosed with hypoventilation syndrome, which is where the CO2 rises for at least 10% of the observed study time. And what that means is the time during which the child was actually asleep with the monitor on. Central sleep apnea is an apneic episode for at least 2 respiratory cycles, crucially without respiratory effort. When that happens, in an infant, so in a neonate, it's not uncommon, but in any child older than the age of 1, then should consider Chiari malformation, metabolic disorders, whether medications could be causing it or other neuromuscular problems. Management of OSA, the first line is adenotonsillectomy, although CPAP is an option where it's tolerated. A straightforward adenotonsillectomy is something that I'm sure everyone's familiar with, but a drug-induced sleep endoscopy is a slightly more thorough way of assessing the airway. So it's a spontaneously ventilating technique with children sedated and unconscious, but as close to physiological breathing as possible at the start of the procedure. And it has the additional benefit that it allows to assess for multiple levels of obstruction, such as the tongue base, soft palate, upper airway above the glottis, and that can be useful certainly for revision cases and also for cases where there's discordance between the tonsil size and the severity of symptoms. Pre-op overnight saturations monitoring is not always needed for diagnosis, but it is being used in some centres to help push towards day case adenotonsillectomy. So, for example, in Newcastle, there's a new protocol where children have a pre-op domiciliary sleep study, and if there's no desaturation, then it means that moderate or severe OSA has been excluded, and those children can be candidates for day case surgery. But the standard post-op management for OSA is 1 night in hospital with saturations monitoring and ITU admission if there's significant comorbidity. Important to consider comorbidities such as sickle cell thalassemia trait, and have a conversation with the parents about transfusion, which could be just 1 sentence if they're happy with it. But if the parents are unhappy with transfusion, that's very important to know preoperatively. It doesn't mean the patient can't have the procedure if it's indicated, but there are measures that can be taken to minimize the risk of needing transfusion. Moving on to talk more broadly about the airway itself then. There are multiple differences in physiology between children and adults, but the main take-home message is that the infant larynx is high, anterior, and small. So it's different to access it than in an adult with laryngoscopy. The subglottis is the narrowest part, which is bad because it's a fixed ring. It's a complete cartilaginous ring. In an adult, the narrowest part is the glottis. A rule of thumb for estimating the ET tube size is age plus 16/4. There are other formulas that can be used. Something I'll mention on the next slide is my rule of thumb for selecting which bronchoscope to use is size 3 for a term baby, size 4 for a 1-year-old. And you can, if you remember those 2 hooks, then you can work out what's likely to be the appropriate size for a preterm, a 6-month-old, an 18-month-old. That's when it's an emergency, or if you're sitting in an exam. In real life, the other thing you can do is look at the Great Ormond Street airway sizing chart, and it's useful to have that on your phone or on the wall of theatre. So evaluating children, you need to look at the work and rate of breathing, look for recession, tracheal tug, signs of cutaneous lesions, because 50% of children with cutaneous hemangioma may have, sorry, other way around, 50% of patients with airway hemangiomas presented with cutaneous lesions. Think about feeding issues, partly because that could suggest a structural problem such as a laryngeal cleft, but also neuromuscular problems, and any other breathing problem simply makes it difficult for babies to feed because they can't feed and breathe at the same time. Look for dysmorphic features, and certainly don't rely on the saturations of oxygen, because if the saturation falls, then that is, in the acute setting, effectively a pre-terminal sign. More useful is looking at the transcutaneous CO2, which if the CO2 is rising, that's a sign of a child who's working hard and tiring and potentially in an emergency situation. Characterizing stridor, try and describe the stridor as clearly as you can, specifically mentioning whether it's inspiratory, biphasic, or expiratory, and try and pass comment on whether it's harsh, soft, high-pitched, or any other character that you can attribute. In broad terms, inspiratory stridor is glottic or supraglottic. Biphasic stridor is subglottic or at the tracheal level, and expiratory stridor, if it's purely expiratory, is typically lower tracheal or bronchial in origin. And it's also possible and quite common to have multi-level obstruction as well. Routine investigations, flexible laryngoscopy, if it's safe to do so, which it usually is apart from emergencies. FEES, which is fiber optic endoscopic examination of swallowing, or modified barium swallow, the latter of which does require x-rays and has that downside, but also the former of which requires more cooperation, useful for feeding issues. Chest x-ray really only if there's a suspected foreign body. CT or echo for extrinsic tracheal compression. CT was the has historically been the first investigation for a patient with tracheomalacia, where an aberrant artery pressing from the outside of the trachea is suspected. Although there is a move towards using echo in the first instance, which can be an accurate instrument, and if it's normal, then no X-rays would have been needed. MRI is certainly useful for suspected lymphovascular malformations, suspected or known lymphovascular malformations, but more likely to require a general anaesthetic depending on the age of the child. MLB, flexible bronchoscopy, is effectively the definitive airway examination, and depending on the skills of the operator, it may be one person who does that, or not uncommonly, and for exam purposes, it's worth mentioning that you'd work closely with a respiratory physician, and both an ENT surgeon and a respiratory physician would commonly examine the airway together in theatre. So you may be asked, how would you do a microlaryngoscopy and bronchoscopy? And the only real way to learn that is to do it in real life. But as a reminder, it's a general anaesthetic procedure with the child spontaneously ventilating, which means it's a light anaesthetic, and so they won't have lost their cough reflex. And so because they still have a cough reflex and you're about to instrument the larynx, you want to put 1% lignocaine spray to the glottis and to the carina, and then insert the bronchoscope and evaluate for malacia, stenosis, complete rings, fistulae, clefts, masses, vocal cord movement. And remember that a laryngeal cleft, the only way to exclude that is to actually palpate the interarytenoid tissue. There's the rule of thumb, which I use in my mind for sizing a bronchoscope in an emergency or in an exam. The Cotton-Meyer grading scale is a commonly used system for determining the amount of airway narrowing. Remember that Purcell's law is the relationship of diameter and airway resistance, and a drop in airway size of 50% leads to a 16 times reduction in airflow, or a 16 times increase in the resistance to airflow. Remember, when assessing this, it's difficult to grade Cotton-Meyer just by looking. The most accurate way of assessing subglottic stenosis is to intubate the patient and see if there's an air leak. That has to be done only once and not forcefully. Remember to use the outer diameter of the ET tube. So, for example, a size 3 ET tube wouldn't be a 3 millimeter diameter. 3 millimeters there is the internal diameter. Depending on the brand, it may be 4.2 or 4.3 millimeters on the outside. Once you've measured the diameter of the subglottis, then there are charts that you can look up what the expected diameter would be for the patient's age, and then that can then give you a number, percentage obstruction. That's a much more accurate way of assessing than just eyeballing and saying, looks about 50% obstructed. There's some pictures of subglottic stenosis. When it's really obvious like these pictures, then it's obvious, but assessing between grade 2 and grade 1 or even normal can be difficult. One slight problem with the Cotton-Meyer system is that technically everyone has grade 1 stenosis, because someone with 0% narrowing is still in the grade 1 category. So typically you wouldn't describe grade 1 unless there was, visual signs of stenosis, but it's less than 50%, or symptoms of stenosis, but less than 50%. There's some typical findings of laryngomalacia, tracheomalacia, and a complete ring. Notice that the complete ring is quite subtle, and it's the sort of thing that you only really see if you're actually, specifically looking for it when doing the examination. Tracheoesophageal fistula and esophageal atresia is a spectrum of a group of problems which generally come together. The most talked about one is probably the H-type TOF, because it's kind of easy to visualize, but the most common one is type C, which is where there's a blind ending upper esophageal tract and then a fistula heading from the trachea down towards the stomach. And that's commonly diagnosed by airway problems, cough, sometimes referred to as a TOF cough, and difficulty passing an NG tube. That would prompt suspicion of this, and it would be investigated with microlaryngoscopy, bronchoscopy, and proceeding to repair, usually immediate repair straight after the MLB. On the left here we have a view of the distal trachea, the left main bronchus, the carina, and the right main bronchus, and then this absolutely walloping big fistula just there. It's almost never as obvious as that. This is much more realistic. Unfortunately, patients don't come with an arrow pointing to the pathology, but you can see how subtle a tracheoesophageal fistula can be. And again, it's really the only sort of thing often that you spot if you're actively looking for it, and it can be very easy to miss. The types of presentations children present with, laryngomalacia is typically an inspiratory high-pitched stridor. Tends to be worse while supine, feeding, or crying. It classically isn't present at birth. It presents within the first month or two and then peaks around 4 to 6 months and tends to resolve around 12 to 18 months. That's very variable. It is absolutely possible to have laryngomalacia from birth, and it is possible to go on beyond 18 months, but that's just a typical expected route. It's worth treating reflux. There's a close association, both because laryngomalacia can mechanically cause reflux, and also reflux can probably cause laryngomalacia through a neuromuscular, neuromuscular problems. Effectively, it can affect sensation of the larynx. That's one of the several theories about how laryngomalacia comes about. It's not quite as simple as just floppy cartilages. Remember that only 10% of children need a supraglottoplasty. For the majority, conservative management is sufficient. And apart from cases of extremis, such as cyanosis, sternal recession, a child who's obviously struggling to breathe in front of you, the most useful indicator in the outpatient clinic as to whether a child needs a supraglottoplasty is the child's weight. Babies who struggle to breathe struggle to feed, so they take in fewer calories. And also, they burn those calories by spending all their time working on their breathing. So a child who's dropped off 2 centiles is a pretty solid indication for supraglottoplasty if laryngomalacia is the diagnosis. Tracheomalacia, on the other hand, presents with typically a biphasic stridor, usually which is worse while upset. And laryngomalacia does have episodes of quietness and noisiness, but in tracheomalacia, that effect is much, much more pronounced. You can have a baby who's just absolutely comfortable, breathing absolutely fine, no problem, and then they suddenly go into a very severe, very sudden crisis where they start crying, start getting stridulous, cry a bit more, get more stridulous. Consider extrinsic compression when tracheomalacia is diagnosed. Positive pressure airflow, such as CPAP or high-flow nasal cannula is usually all that's required, but in complex cases, surgery such as tracheopexy, aortopexy can help to change the shape of the airway. Vocal cord palsies are not uncommon, but particularly consider it after a child's had any kind of heart surgery, especially if they present post-operatively with a weak cry, aspiration, or stridor when upset. Stenosis can happen for multiple reasons, including being idiopathic. Always consider subglottic stenosis after a child has been intubated for any length of time, and always ask about intubation during your history. LTR, CTR, and slide tracheoplasties are all forms of advanced airway reconstruction, but I've decided that they're slightly beyond the scope of this talk. There's a view of recurrent respiratory papillomatosis caused by HPV type 16 and 18. treated with serial debridement, but also on the other hand, airway trauma can also stimulate new growth of new lesions. In countries where the quadrivalent vaccine is being given at a population level, this disease has effectively been eradicated. In the UK, it's still relatively prominent, but definitely there's evidence of vaccination playing an increasing role. On to infections. Laryngotracheal bronchitis, also known as croup, is a common cause of stridor, and probably the most common cause of acute stridor, and it tends to come on over 3 to 7 days. It's technically an airway emergency, but also if a child with croup is intubated, then that can lead to a prolonged ITU stay because the ET tube can cause more edema and it can be difficult to extubate them. The best treatment is conservative management, which means giving a steroid, nebulized adrenaline, consider stenosis if it's happening recurrently. And I'll come back on to airway emergencies in a moment.
Can I interrupt for a minute? Is it 6 or 11 or 16 or 18, the subtypes of HPV which causes RRP? Is 16 or 18 or is it 6 or 11? I mean, what is the...
To be honest, I'm pretty sure I copied that out of the textbook without actually processing it in my mind. I think you're right about 11. I think it may be 11. Do you know, I'm sorry, yeah, I can't remember off the top of my head, but thank you. I think you're right. It is probably, I think it is 11.
So 16 is more like for the head and neck squamous cell. Anyway.
Yeah, you're absolutely right. My mistake. Thank you for pointing that out. Back to bacterial tracheitis. It's the difference between that and croup is more likely to be presenting acutely, so within 24 hours, more secretions, and more likely to be associated with fever. It can be difficult to diagnose clinically, but if a child has MLB, then those are the things that can become obvious. Supraglottitis is an airway emergency, also known as epiglottitis. These are the sort of images that shouldn't really be taken in A&E, but sometimes they're done as part of a differential. But remember that a child with suspected supraglottitis, the first priority is to secure the airway. This picture is an inflamed epiglottis, which is almost completely occluding as compared to a normal laryngoscopy view. Okay, I'm just going to come back to those pictures because this is the important thing, both for real life and for your exam. When confronted with a scenario and it's clearly the examiner is letting you know that this is an emergency, say that it's an emergency. Make that your first thing. Say, this is an airway emergency in a child, and I'm going to need help from a pediatrician, an anaesthetist. If you're a registrar, then call your consultant, and if you're a consultant, then perhaps call another consultant. They need level 3 care, which means either resus, theatre, or PICU, and manage in the initial situation with supplemental oxygen. It's important that you don't want to upset the child, but children tend not to be upset by having a face mask being given with ambient oxygen just to the side of them. Heliox can be helpful if it's available. It's not always available. Nebulized adrenaline and dexamethasone are always available. Elevate the head. Avoid radiology in the case of a child who's clearly got an airway emergency. The first priority is to secure the airway, and the safest way to do that is in theatre with an experienced anaesthetist. Obviously, there's more to it. There's more to managing airway emergencies, but that's your kind of those are the hooks in your mind to remember to say. Now, I didn't go into a great amount of detail in foreign bodies, but what I will say is this: I won't pick on an audience member to say which one is more worrying, but just consider which of these pictures is more worrying, and then I'll tell you the answer is the one on our left, and the reason is that's a button battery, which is an absolute emergency. It has to be taken out immediately. And the reason is not only because of the mechanical effect of it being a foreign body in the airway, also there's a chemical problem that lithium batteries can leak and that can cause a caustic injury. But even that is less than the chemical effect of an electric current. So basically the local electric current set up by a battery dissociates hydrogen and oxygen dissociates water into hydrogen and hydroxide ions. The hydrogen then covalently pairs to form hydrogen gas, leaving hydroxide ions, which is alkali or basic, and so with any button battery, there's a very, very strong caustic alkali injury, and the first priority is to take the button battery out. And there's evidence in favour of and guidelines in favour of irrigating the area with 0.3% vinegar, basically 0.3% citric acid. The one on the right is a coin, but if in doubt, assume it's a battery until you're absolutely certain otherwise. The clue is the halo sign around the battery on the left. You can see that there's the radio opaque shadow, and then just inside the margin, there's another line that you can see, which on this view, on the right-hand image, you can see that there's a slight bevel to the foreign body in the lateral view, and that's a battery until proven. Well, that's not a battery until proven otherwise. That is a battery. It needs to come out. Okay, so I'm certainly not going to be able to get through everything in this topic, but we'll move on. Rhinology has a lot of overlap with adult rhinology, but remember that these are the sorts of things that present in children. If there's a congenital nasal mass, consider that it might be a nasal dermoid. That's probably the most common thing for a child who presents with a lump on the back of the nose. But the important thing about it is that they need to have an MRI scan to confirm that there's no intracranial extension, which basically means to confirm that it's not a meningoencephalocele. A dacrocystocele, when it presents on the outside of the nose, tends to present laterally at the angle of the eye, but also can present with nasal obstructive symptoms. 85% resolve spontaneously by 9 months. The remainder undergo either canaliculus cannulation or endoscopic marsupialization, or both, and that's called a DCR. I'll move on from those there. But well, the cysts and pouches are quite rare, but choanal atresia is common. That's one to know about. Persistence of the bucconasal membrane, 65% unilateral. Mostly they're mixed bony and membranous. Purely membranous choanal atresia is extremely rare. When it's identified, consider these syndromes: Charge syndrome, DeGeorge, Apert, Cruzon, and others. When it's unilateral, it can present at any age, but bilateral choanal atresia almost always presents in the neonatal period because babies are obligate nasal breathers for the first couple of months. Another reason that it can be diagnosed is a referral to ENT with a history of difficulty passing an NG tube. Consider neoplastic nasal masses. I won't go into a great amount of detail, just know that they exist. They exist in benign and malignant forms, and especially consider it when there's a unilateral mass. Same with vascular masses. JNA technically is actually a neoplasm, but I've put it in the vascular category. It's a very vascular lesion. This is important to remember for any child who presents with unilateral nasal obstruction and epistaxis, especially in boys. And those are some images: T2 MRI there, T2 MRI here, CT there, and angiography showing this nest of abnormal vessels arising from the sphenopalatine artery. And on CT, if you see broadening of the sphenopalatine foramen, then it's essentially pathognomic of JNA. Hemangiomas and arteriovenous malformations are a topic all by themselves. And what I'll say about that is definitely learn this. This is the ISSVA classification. And each of these categories then has lists and lists and lists of syndromes that you can find, but just know that these are the broad categories that are described in the ISSVA classification. Okay, rhinitis also, there's overlap with adult, and there will be a talk in a moment on rhinitis, so I won't go into a great amount of detail. I suppose the important things I'll say is it's common. If there's a polyp in a child, an inflammatory polyp in a child is virtually 100% guaranteed. Well, virtually 100% of children with inflammatory polyps will either have PCD or CF. Without one of those two conditions, polyps in children do not happen. So definitely consider further investigations for that if you see bilateral polyps. Rhinolith is what's left over after a
PCD means what? PCD, polycystic. What is PCD?
Primary. Sorry, thank you for pointing that out. Primary ciliary dyskinesia.
Okay, fine. Thank you.
Primary ciliary dyskinesia, and CF is cystic fibrosis. You can see that I'm going a bit fast because I'm running out of time. So what I'll do is I'll stop very soon because I think there is a specific otology talk, and the only other thing I was going to go into after this was branchial arches. These are the useful things for hearing tests, the useful ages. Remember that hearing behavioural and non-behavioural hearing tests. Well, you can't do behavioural hearing tests at a young age, and the older a child gets, the more. And after that, ABR and otoacoustic emissions can be done as a form of non-behavioral test, but ABR may require general anaesthetic at older ages. Visual reinforcement audiometry is used in children up to 4 years old, and from 4 or 5 years old onwards, they can then comply with normal pure tone audiometry. Remember, when using tympanometry, which is a useful test because it doesn't require cooperation, in neonates, you have to use high frequency tympanometry. And the reason is it's because of physics, but basically, in simple terms, the ear is smaller, and so you need the sound waves to be smaller. So they use higher frequency sound clicks to stimulate the response. The newborn hearing screening program, probably the important thing to know about it is that it's offered to everyone, and there are 2 different pathways. There's the well baby pathway, which I'll just skip forwards to the summary. Well baby pathway, they have otoacoustic emissions. If they fail that, they have it again, and if they fail that, they get automated ABR. If they fail after all those, or if they have any risk factors, then they're referred. For PICU babies, there's a lower threshold for referring because the risk of sensory neural hearing loss in well babies is 1 in 1,000. The risk of sensory neural hearing loss in babies who've been to PICU is 1 in 100. So they're more likely to be referred. And those risk factors are on this slide here: torch infections, meningitis, prematurity or low birth weight, abnormal APGAR scores, hyperbilirubinemia, hypoxia, and family history. Okay, I'll stop because I've spent half an hour talking, and there's this is obviously a huge topic, but I think I've said the important things, and everything else I was going to say, there is a lot of overlap with adult type topics. But I'm going to be around all day, so I can try and answer further questions if anyone has any, and I'll also be doing the Viva sessions later on as well.
Brilliant, thank you.
Hope you found that helpful, everyone.
Thank you very much, Matthew. I know it's difficult or challenging topics to give in 30 minutes. I think you covered, more than an hour worth of topics. Honestly speaking, the pediatrics is one of the challenging station, particularly if you're not exposed to dedicated pediatric ENT posting. Only even in UK, not many centers offers that in their rotation. They do understand that one, but unfortunately, still it is a kind of big part of 4 major stations. Thank you very much, Matthew. I think I'm very grateful for your talk. Great.
Thanks.
I think there's some questions in the chat.
Yeah, it's right about the HPV. I got the numbers wrong there. I was too hasty when putting the slide together. That's definitely my mistake. Yeah, the acetic acid. It was previously avoided because the theory is that an acid plus an alkali can cause a thermal reaction. And there were some in vivo studies where if you take a strong acid and a strong alkali, you can generate temperatures up to 70 degrees. But actually, if you use a weak acid, so 0.3% strength, then that's essentially, it's enough to mop up the excess hydroxide ions without causing any thermal injury. And that's based on multiple in vivo and in vitro studies, which show that it definitely arrests the chemical burn. It doesn't cause a thermal injury, and it significantly reduces the risk of perforation, and perforation is the concern.
Brilliant. I was going to ask another question, actually. I think it's in the chat box as well. Can you share the presentation? It's very useful. I do felt that because it's
Was that the assessment of subglottic stenosis?
The presentation of your talk. Is it? Can we share that? That's what they're.
Oh, yeah. There's some. Not all of the images are mine, but they're all public domain. So I've put references to the images that were non-public domain, and the rest of them are all off Google. So yeah, I'm happy to send. Shall I email that? Shall I email the talk to you?
Yeah, that would be great because it's loads.
Okay.
Thank you.
Not at all. Okay.
We will move on to the next speaker, Bhaskar Ranganathan. He's a consultant from Manchester, rhinology. He's going to give a brief update about some hot rhinology topics. Bhaskar, are you there?
Yes, yeah. Thanks, Jay. Can I share my slides now?
Yeah.
Just give me a second. Nearly there.
Good.
Yes.
Yep, it's about to.
Yeah. Can you see my slide now?
You can see your slide. Maybe you may have to switch on your camera so that we can see you as well.
I think it is on now. Can you not see me?
It's all right. We can't see you, but your slides are up. Fine. Go ahead, then.
Okay. Yeah. Can you see me now? Yeah. Thanks, Jay. Thanks for inviting me. You can see my slide now?
Yes, it looks absolutely.
Yes. Yeah. Excellent. So the next 20 minutes, I'm going to cover these 3 important topics. I'm going to mainly focus on the updates on chronic rhinosinusitis, basically the EPOS 2020 guidelines, and the updates from ARIA guidelines. And also I'm going to talk about the orbital cellulitis, which is really one of the very important topic. So every time they release the guidelines, they add a couple of hundreds of pages in the EPOS. So the latest one has got about 480 pages. So you're not expected to know everything, but I think it's worth spending to read the first 20 pages, which is kind of an executive summary, which has got everything, like the management, definition, classification. I think it's worth spending just reading that. So the definition remains the same. So from the previous EPOS guidelines, it's inflammation of the nose and paranasal sinuses. They should have 2 or more symptoms, one of which should be nasal blockage, nasal discharge, plus or minus facial pain and anosmia. This should be supported by, there's an objective evidence of endoscopic finding. There should be either polyp, mucopurulent discharge, or edematous mucosa, or CT changes of chronic rhinosinusitis. So since the last guidelines, there's been a lot of research gone into to understand the pathophysiology of the chronic rhinosinusitis. So previously, it was simply classified as chronic rhinosinusitis with nasal polyp, with polyp or without polyp. So it is too simplistic. But now, with a better understanding of the pathophysiology and understand, they've subgrouped based on the endotype, which is the biological characteristic of that each disease. So they've also updated the integrated pathway, and with the subtype, we have, we can target the right treatment, either surgery or the medical treatment or the combination of that. There is a lot of interest now on the biologics, which I'll talk about it a bit later. So they're divided into broadly classified as a primary and secondary CRS. So primary CRS means it's purely a sinus mucosal inflammation. So based on the anatomic distribution, they broadly divided that into a localized, that is mostly a unilateral, confined to one anatomical subunit, or this could be a diffuse, often a bilateral disease. So this is what I've discussed about the endotype, that is, whether they got the type 2 inflammatory disease or whether it's a non-type 2. So there are some examples based on this subgroup, which I'll go through in detail. So first is the allergic fungal rhinosinusitis. The patients have got characteristic allergic history, IgE positive, and they can have like a unilateral purulent discharge. As you can see in this scan, the allergic fungal sinus is just very confined to the maxillary sinus. If you're in doubt on the CT scan, you can always ask for an MRI scan, which shows a very characteristic hypo-intense on the maxillary sinus on the T2 images. So that's how you differentiate. So here, the treatment modality is the surgery. There's no point in giving any antibiotics or steroids in these patients. What's happening here is the mucosa is sensitive, so there is a allergic response to the common fungus, but because of the unfavorable anatomy, this fungal mucins clogs into the sinus and blocks the middle meatus. So they form a very thick, what we call is like a peanut butter mucin with the fungal debris. So the treatment here is surgery, straightforward surgery, wide antrostomy, and then yes, post-operatively they'll need some care. They'll need steroid-based spray or oral steroids, and rinsing the maxillary sinus. So localized, but it's not a type 2 inflammation. So they can have like an isolated sinusitis. For example, they can have an isolated frontal or isolated sphenoid or ethmoid sinuses. Patient presents with unilateral purulent discharge, not responding to the medical treatment, but they don't have any history of asthma or allergy symptoms. Here again, straightforward, if they're not responding to the medical treatment, surgery to open up the sinus so that it can drain freely, and the symptoms should resolve. So now we'll move on to the diffuse category. That is the patients where they have bilateral disease. If they have history of allergy and asthma. Sorry, just 2 seconds. Yeah, so there's a diffuse involvement. So these patients have got the characteristic history of allergic rhinitis or asthma, and the 3 common type 2 inflammation with the diffuse involvement, or our classic chronic rhinosinusitis with the nasal polyposis, bilateral allergic fungal sinusitis, and the other new category is the central compartment disease. So this is very familiar. It's a bread and butter in the rhinology clinic. We see patients usually present between 30 to 40 years. They would have had an adult onset asthma, or they might have had allergy issues since childhood, and then it's just exacerbated now. So they'll have a very diffuse type 2 inflammation of the nasal mucosa with bilateral nasal polyposis. What they need is the initial treatment is medical treatment, and if they don't respond, then surgery. And in patients who don't respond to both of that, they may need biologic treatments with monoclonal antibodies. So the next one is allergic fungal rhinosinusitis, which we discussed before. But here it is a bilateral involvement where is a classical CT scan showing double density because of the minerals. And also you'll notice that there is a generalized erosion of the sinus wall and expansion of the sinuses. They're not invasive. So these patients are immunocompetent. Again, classically thick allergic mucin clogging up the sinuses, not responding to the medical treatment, and they'll have history of allergy, and the IgE count will be very high. And again, here the treatment, probably the medical treatment may not work, so the treatment is aggressive surgery, opening up all the sinuses, removing all these allergic mucins. If we don't clear the allergic mucin, it just stimulates the inflammatory cascades again. So the next one is central compartment atopic disease. This is kind of a new entity, but it's a well-recognized entity. These patients have got severe allergic rhinitis, and it just involves only the central compartment, that is just only the nasal cavity. And on examination, you'll see like a very classical jelly-like polypoidal appearance of the middle turbinate, superior turbinate, and the inferior turbinate. As you can see, the rest of the sinuses are pretty much normal. But if you don't treat it, these polyps can obstruct the osteometal complex, and then the disease will spread from medial compartment to the lateral compartment. So it's involving the maxillary, ethmoid, and then frontal and sphenoid sinuses. So here again, the treatment is combination of medical, and if they're not responding, surgery to remove those polybody changes. So there are a group of patients who will not have any history of asthma or allergy, and the blood test Ig is normal, eosinophils are normal. They're classically older people or chronic smokers, where they got a polypoidal changes, purulent discharge from both nostrils, not responding to the steroids, not responding to the short-term course of antibiotics, and even after surgery, they may still have lingering infection. So they fall into the category of non-type 2 diffuse, diffuse involvement. As you can see in the CT scan, there's a generalized mucosal thickening, most of the sinuses, despite having wide opened middle meatal antrostomy. So these patients may not, will not respond to the steroid, but they may be good candidates for medical treatment, like a long-term low-dose antibiotics like macrolides. So the second broad category is the secondary chronic rhinosinusitis. Again, they are divided based on the anatomical distribution, either localized or diffused involvement. So here, the secondary chronic rhinosinusitis, it is not a primary sinus mucosal involvement. It's a sinusitis is secondary to either a localized problem or a systemic disease. So in a local pathology, the classic examples are like odontogenic sinusitis. So there's a very high chance you might be put a scan like this, and you may just ask to read, and they may take you through this. So classically, this patient present with very offensive unilateral purulent discharge, and if you do a CT scan, there is the opacification of the maxillary sinus. And patients, if you ask the patient, they may have had a root canal treatment recently or a dental infection. So it's very important to recognize this odontogenic sinusitis, because there's been increasing root canal treatment, and we are seeing more and more patients coming to our clinic. So this patient should be managed with the oral dental department and oral surgery department. So unless they treat the primary root problem, even doing a surgery may not be helpful. I've caught up sometime, like the dentists have cleared, there's no dental infection, and you do a maxillary antrostomy, you drain everything. Within a few weeks' time, patients will come back with purulent discharge. And if you look inside, there's a very unhealthy granulations in the maxillary sinus. So it's important to recognize these patients and treat the problem, the root problem. The other one is fungal boil. This is different from allergic fungal sinusitis that we discussed before. Here, again, the patient don't have any history of allergy, IgE and eosinophil counts are normal. These are just a fungal boil, occluding the osteometrial complex, and that's triggering the cascade of infection and inflammation. Here, the straightforward is do a surgery to clear this fungal boil and do a wide antrostomy. Yes, tumors, either benign or malignant tumor, can obstruct the drainage, the sinus drainage, which causes sinusitis, and it's often unilateral. And the most commonly that we come across is inverted papilloma, which is a really important topic for exam. So again, the treatment is treating the tumor and addressing the tumor and blocking those sinuses. So diffuse pathology, where this is due to the systemic disease, which is causing sinus inflammation. One is the mechanical problem. That is one of the classical thing is cystic fibrosis, and cystic fibrosis, where there is mutation in the CTFR gene causing problem with the chloride ion channel. So the mucus gets thickened. That is 4 times more thicker than the normal mucus. So it forms like an ideal breeding ground for like a pseudomonal infection. So as my previous speaker explained, a child with classical patients, or like a child with a nasal polyposis, you always think about cystic fibrosis or primary ciliary dyskinesia. So here the patients will have pansinusitis kind of picture with contracted frontal and maxillary sinuses. You can see that you notice that there is a bowing of the lateral wall of the maxillary sinus, and there's a classical aplasia of the frontal sinuses. So here the treatment is a combination of surgery and the medical treatment. And more than 80 or 90% of patients with cystic fibrosis will have sinus involvement. So the second thing is the inflammatory diffuse involvement of the sinus secondary to autoimmune conditions. So if a patient comes with a chronic rhinosinusitis picture, you've done a medical treatment, steroid treatment, antibiotics, not responding, then the immediate thing is to think about whether they got any autoimmune conditions. So it's, I think we should all have a low threshold to do this blood test, to do an autoimmune screen. The common one that we come across is the GPA. So the treatment for them is, again, urgent referral to the rheumatologist, working closely with the rheumatologist, and starting immune suppressive medications. That's the treatment. As soon as they start the medication, you will notice a good improvement with the nasal mucosa. Most of their sinus symptoms will settle down, but we still need to review them every 6 months or so, just to keep an eye on it. The nose is like a mirror or like a mirror for the autoimmune condition. Often we tell the rhinology, the rheumatologist, that is there a flare up, or is there a autoimmune conditions is surging. So there are a group of patients where they'll have recurrent acute sinusitis, not responding to the medical treatment. And those subgroup of patients, we need to think about whether they got any autoimmune, whether they got any immune compromised conditions, like they may have diabetes or HIV, or they may have like a selective immunoglobulin deficiency. So again, checking the checking the immunoglobulins will be helpful. Again, those patients will need a different set of treatment. You need to work with the immunologist and with the medical people, and they are completely different entity. But it's important to recognize this condition in patients who are presenting with recurrent sinusitis, not responding to the maximum medical treatment. I'll not go through everything in detail, but I think the diffuse CRS, that is a type 2 inflammation, bilateral polyposis, are the classical, and they are the bread and butter of our rhinology service. So those patients will require saline nasal douching, intranasal corticosteroids, either sprayed, drops, oral corticosteroids. By just taking simple history and doing blood tests like checking the IgE and the eosinophils, you can divide them into type 2 or non-type 2. This will make a difference in how you're going to manage those patients. In non-type 2 patients, they mainly present with purulent discharge, facial pain, and what they need is the long-term. You can try with the long-term antibiotics like macrolides, because they're not going to be steroid responsive. And if they're not responding to the antibiotics, then you progress. You do endoscopic sinus surgery. Whereas in type 2 conditions, they'll have background history of asthma and allergy. Their main concern will be bilateral nasal obstruction, losing and hyposcopy. So those patients will have elevated IgE and the eosinophils. And the medical treatment is the intranasal steroid or oral steroids. If they're not responding, then you progress to the surgery. So patients who are not responding, type 2, not responding to the maximum medical treatment and surgery, then you consider biologic treatments. So this is like a breakthrough in the management of diffuse chronic rhinosinusitis with nasal polyposis. they are like a game changers. I think, it's important even for your practice as well as for your exam. I think you should read around this topic and understand and have a good idea. So what does the prednisolone or the steroids do? It suppresses the whole immune system. Whereas this biologics, the monoclonal antibodies, targets a specific inflammatory cascade system like interleukins, interleukins, IgE, and so that you're not giving a complete systemic suppression of the inflammation. With the steroids, you have all those side effects, but by targeting those specific interleukins, you can manage the symptoms better. So this is like a landmark publication in the Lancet, published by Klaus Bashert, that this is randomized RCT using placebo and dupilumab. You can see on this graph, the response, how they respond very well to the dupilumab. Most of their nasal sinus symptoms significantly improves. And if they continue, there is, you can see that the graph, there's a significant difference between the placebo and the dupilumab. But the downside is if you stop, the symptoms comes back again. So that's something that we should keep in the mind. So the pros and cons of monoclonal antibodies. The advantages, it's a non-invasive. It responds. It can control both upper and lower respiratory symptoms. What are the surgery or the medical treatment that we give? Usually, most of the patients don't regain the sense of smell. But whereas in monoclonal antibodies, even after giving few doses of dupilumab, they'll see a big difference in the sense of smell. So these are again ideal for patients who are not suitable for surgery or who have failed all the medical and surgical management. But they are very expensive. I think it costs about £1,200 for a single dose of dupilumab, which is almost equivalent to a surgery. So they're probably in coming decades or coming years, the cost might go down. This may be the standard of care. But as I said previously discussed, they need to be taken for a long time. So they're not disease modifying, it's only a disease controlling agent. So they need to be taken for lifelong. And we don't know because it's only we've been using it for the last few years. So we don't know the long-term side effects of monoclonal antibodies. But I think there's been some reports that patients who have used for more than 10, 20 years, there is a slight increase in incidence of hematological and liver malignancies. Okay, the EPOS has come up with the criteria who will be suitable for monoclonal antibodies. What they looked at is whether there should be a confirmation of type 2 inflammation with eosinophils, increased eosinophil and IgE count, or the patients are requiring more than 2 courses of steroids, and persistent worsened symptom with a SNOT score of more than 40. So those patients, if they meet any of these 3 criteria, they should be eligible for the monoclonal antibodies. So we'll move on to allergic rhinitis. Again, I'll just focus on what is being updated with the latest ARIA guidelines. So again, the definition remains the same. It's an IgE-mediated inflammation of the nasal mucosa. And when they're exposed to the allergen, they'll have watery, excessive sneezing, watery rhinorrhea, and nasal obstruction. So if these symptoms last for more than an hour per day, then they fit into this allergic rhinitis criteria. They should be supported by either a RAS test or a skin prick test. So previously, allergic rhinitis was divided, broadly classified into perennial or seasonal allergic rhinitis. But now they moved from that because of crossover of multiple allergens. So now they're based on the duration and the severity. So during the duration, if it is less than 4 days per week and less than 4 weeks, then it's intermittent symptom. Then if it is more than if they are affected more than 4 days per week and lasting more than 4 weeks, then they have persistent symptoms. Again, they divide the severity into mild or moderate to severe. Mild means there's no problems with your day-to-day activities, sleep, your school, school or other activities. But in moderate to severe categories, they may have problems with the sleep disturbance. It's affecting their day-to-day life, affecting their work and school, and that symptoms are more troublesome. So 40% of 40% of patients with allergic rhinitis may have asthma. So there is this concept of unified airway clinics or getting popular nowadays. You're working closely with the immunologist and respiratory team, so managing patients with severe allergic rhinitis and asthma in this clinics, which is beneficial. So the treatment for allergic rhinitis, again, the 3 modalities. One is allergen avoidance. So you know what you're allergic, what you need to avoid, and you follow that. That reduces the symptom. And the pharmacological treatment. That's basically intranasal steroids and antihistamine. So if they fail to respond to the pharmacological treatment, then you consider for immunotherapy. I will not again go through the all this new guidelines for treatment, but what I want to emphasize is they divide them into step up, step down treatment based on the visual analog score, the severity of the symptoms with the visual analog score. So here is the evidence of different treatments, and you can see the Dymista, the intranasal corticosteroid with antihistamine, is like a game changer. You can see that it controls most of the allergic rhinitic symptoms more effectively than the other medications, and also it's fast acting. Once you spray, it acts quickly and it lasts long. I think it made a big difference, and most patients are happy using Dymista. The next thing is the immunotherapy. I think if they just get into this allergic rhinitic topic, I'm sure they'll get into, they will go on ask about the immunotherapy. So there are two types of administration. One is the sublingual and the other one is the subcutaneous. I think they started with the subcutaneous treatment, but I think the sublingual treatments are getting more popular. They either give it like a gel or a tablet. You just place it under the tongue, and this can be managed. Even the compliance is better, and this can be used even in a pediatric population. Even less than 5 years old can be managed, treated with sublingual immunotherapy. Obviously, the first dose, they need to be administered under supervision in the hospital. If they don't have any response, then the treatment can be continued at home. So montelukast is really helpful in patients who've got allergic rhinitis with asthma, so they respond well. There is a role for monoclonal antibodies, but the downside is it's too expensive to manage allergic rhinitis. Is there a role for surgery? Certainly, there is no role for surgery to manage the symptoms, but they are helpful in patients who've got severe nasal obstruction affecting their sleep and having a knock-on effect on the day-to-day activities. Or if you see there is the inferior turbinates are completely blocking the nostrils, then the sprays are not reaching. So in those patients, I think reducing the turbinate size just improves the delivery of the medication, and also they get a temporary relief and they're able to breathe better. So what I use is the mucosal preservation technique using microdebriders, submucosal microdebrider, reducing the bulk of the turbinate. I think the patients are happy. Most of the patients are happy, but we need to warn them that you're not going to cure the allergic rhinitis, but you're only just trying to improve the breathing, and they still need to use spray and antihistamine. So the other important topic is completely different from what I discussed before, periorbital cellitis. I think this is one topic you definitely want to know thoroughly. This can be asked either in the rhinology section or even in the pediatric section. Before we get into the how we manage, I think it's important to understand this. Important to understand the anatomy. What is the period? How you differentiate the pre and post septum or post septal cellulitis. You should be able to explain what is orbital septum, which is an extension of the periosteum from the orbital rim attached to the tarsal plate. So anything anything anterior to the orbital septum, it's a preseptal cellulitis. It acts like a barrier, so it protects the eye. Anything posterior is a post-septal cellulitis. It's common in kids. Most of them are even less than 6 years, often predisposing upper respiratory tract infection, coughs and colds. We don't know why some kids get this periorbital cellulitis, some don't get it, but I think it's to do with the virulence of the bacteria. I've come across patients who had just worsened within a few hours after getting coughs and colds. So, and also we need to keep in mind about patients who got immunocompromised status. So the common bacterial infections which are seen in the upper respiratory system, staph, strep, H. influenza, and moraxella. Either they spread from the sinuses with the bony dehiscence. It can get into the orbit, but often you don't see that any obvious bony dehiscence. It often spreads through the veins and arteries. In kids, it's mainly the maxillary ethmoid. In others, it could be from the frontoethmoidal sinuses. Chandler's classification, very important. So the first type 1 is like a preseptal. So there's no involvement of the orbital content. It's those patients can be managed with oral steroids, oral antibiotics, and often they settle down. 2 is generalized orbital cellulitis, but there's no pus. 3 is subperiosteal abscess, that is collection in between the lamina papracia and the periosteum. 4 is orbital abscess. There is a pus within the orbit, in the content of the orbit. And 5 is cavernous sinus thrombosis, where there'll be a bilateral involvement. I think I would suggest you to read this article from written by Nick Jones. It's a very small, I think 3 or 4 pages, very nicely written and very practical. I think it's very concise. So how do you manage these patients? Assuming that most of them are kids, they need to be seen immediately in the accident emergency department. Apart from the general obs, you need to look at the eye, try to examine the eye, look for chemosis, movement, visual acuity, color vision, and see whether they got any other central signs of involvement. I think that's very important. Whether are they drowsy, whether they got any, are they showing any other neurological signs and symptoms, is very important. And these patients should be managed in a multidisciplinary setting. These are like a keywords when you're answering in your Viva section. You say that I'll manage this child with discuss with the ophthalmologist, pediatrician, sometimes with the microbiologist and radiologist. So you manage in a multidisciplinary setting. Or do the regular bloods. If there are any pus that you can see on the nose, take for culture sensitivity. IV antibiotics, every trust has got different policy. I think in our trust we use IV Cipro and clindamycin. Decongestant, I know the Otrivin, they say you cannot use more than 3 times, but in these patients we prescribe them every 2 to 3 hours, every 2 to 4 hours they need to apply this decongestant. It's really effective. Once the sinus opens up, it can help to drain the pus. You can combine with the steroid drops. And these patients, if you're admitting them, we need to keep a close eye on them. We need to instruct the nurses to do regular neuro and eye ops. Once you assess the patient, there are three important questions that you need to answer: when to admit the patient, when to do a scan, and when to do the surgery. If you know these three, you can manage this station very well. So when to admit the patient, if they are showing any signs of post-septal cellitis, like discussed before, like chemosis, ophthalmoplegia, reduced visual acuity, or if they're showing any signs of central nervous system involvement, I think they should be admitted. Patients who've got immunocompromised status, and if they're not improving with oral antibiotics, or if a young child, and some kids you may not be able to even examine because of the edema of the eyelids. So those patients, I think I'll have a very low threshold. I will not send any child home, even if they have a preseptal cellitis. I want to really keep them at least for a day, because I've seen patients very rapidly, the disease is rapidly worsening within few hours. So when to do a scan, again, it's similar, like those concerns. If they're not showing any signs of central nervous involvement, any concerns with the vision, and if they're not improving with antibiotics, and the pyrexia, it's very important. If you're giving antibiotic and the pyrexia, they're still spiking temperature, I think it's an indication to do a scan. Again, I'll have a very low threshold to admit them. I'll have very low threshold to scan them. So what scan you'll request? It should be a contrast-enhanced CT scan of the orbit, brain, and sinuses. So when to do a surgery? If there are any radiological signs of subperiosteal abscess, it needs to be drained. How do you drain? This depends on your expertise. You can do like an endoscopic or external. I would prefer an external drainage. I think endoscopic drainage is possible. I think if you have that experience, you can do that. That's often very inflamed edematous mucosa, and there's a lot of bleeding. In Manchester, oculoplastic surgeons do the transconjunctival drainage, and in most of the pediatric patients, they take over the surgery. So the advantage is it's a scarless, but to be honest, even the external scar is very small, and it will be hardly noticeable in a few months' time after surgery. Again, if there are any intracranial involvement, you need to involve the neurosurgeons and manage them, combinedly. So that's the end. I'm just thinking about some of the other key topics in the rhinology. Probably want to really focus on this. Rhinology station is like a blessing. If you just know some few topics, you can score really high. So I would suggest you to read these key topics thoroughly. Thank you.
Thank you very much, Bhaskar. That's absolutely a wonderful talk. It's loads of information again. Thank you very much. I know I've been not very kind to you and Matthew in terms of timings, but you've done it.
Sorry, I don't know whether I've overrun or was I okay?
Absolutely fine. I think we are nearly there. So